Great. Well, thank you so much. Looking forward to having this conversation with you all. I appreciate the invitation. And already the results were quite interesting to see that many that are not prescribing GLP-1s are thinking about it. And hopefully at the end of this session, you'll feel a little more confident to do so. And so I appreciate the generous introduction. This this is just a little bit about myself, and we can, some of my work experience, some of my training, and just some fun things. If you want to ask questions later on, how did I come face to face with a tiger and things like that? So what I'd like to do in the next 25 minutes or so is cover four things. One, something important, defining obesity. There have been some new recommendations about how to define obesity, and I think it's important that everyone's aware of that. Uh, then, what are the current indications for the GLP-1 medications? Um, and then, what are the future indications? And then finally, a little bit about the pipeline, because it is a very robust pipeline, and uh, we have options now, but we'll clearly have more in a very short period of time, even within the next few months. So let me talk a little bit about redefining obesity, and the new recommendations that were a series of different uh, national and international societies that have created this new definition. I'll share that with you in a moment. But first, I want to ask you a question. So here are two individuals with a BMI of 31. And I don't know if anybody knows who this person is. There any football fans or people from Philadelphia? Or this person, a TV personality? So Saquon Barkley, running back for the Philadelphia Eagles, and um, a famous Seinfeld character. You can look at them both, and they both have the same BMI. So it shows the limit, right? Like one person, is highly muscular. I don't think we would think that he has a disease in any way. The other one could argue is. And so this is the kind of data that led to these recommendations. So the current definitions, or I would almost say the old definition, was really strictly based on body mass index. Um, uh, as you know, it's weight over height squared, and underweight, normal, overweight, and then obesity over 30. The problem is that this was developed, first of all, European individuals. Asians, for example, this doesn't really hold very effectively because we know that they suffer the consequences of weight at lower BMIs. Um, it's also not a direct measure of body fat, which is really what we're concerned about. Um, and so these limitations have led to the new recommendations that I want to share with you. Um, and that's essentially BMI and one other measure. And the other measure can be one of the three on the right side here, either waist circumference, um, waist to hip ratio, or weight to height ratio. And if you don't have BMI, but you have two out of the three on the right side, that is enough to make the definition of obesity. So the big thing here now is that we're going to start measuring waist and or hip circumference, which really gives a better indication of fat content. So once we think about obesity, we can put people into one of two groups, the first being preclinical obesity and the second being clinical obesity. And it's really important because it'll help us think through who we might treat, for example, and what types of therapy. So those with preclinical, they meet the criteria, BMI plus one other measurement. Um, but they have no clinical consequences of their obesity at this point. And so they function day to day without any limitations, and are not suffering any of the consequences that excess fat. The second group um, is the individuals with clinical obesity. And these are folks that have some clinical manifestation of that excess fat. And so that can be in terms of mobility challenges, in terms of cardiometabolic uh, abnormalities. It can be with comorbidities like liver disease, kidney disease, cardiovascular disease, diabetes, that are all consequences of obesity. So, um, new definition of obesity, and there's preclinical and clinical. So, really, the big message I want to home is that all of us need to have in our exam rooms a tape measure so that that waist or hip measurement can be done. So we can really stratify individuals because when we talk about therapy, it's really stratifying risk and then identifying the appropriate therapy. So here's some interesting data that says if you take the new definition of obesity with the old definition, if you're strictly by BMI, 43% of Americans are living with obesity. However, if you use criteria, that percentage goes up significantly to 69%. Now, of which are individuals with preclinical with clinical obesity. So, with that, I want to move to therapy. And anyone guess what this creature is? It's the Gila monster. The Gila monster it's the saliva of the Gila monster that GLP-1s were first isolated more than 20 years ago. The class has been around for 20 years. And over the last 3 years, of course, it's really taken off because of the newer analogs that have had much more profound weight impact. But if we think of just the basic mechanisms of GLP-1s, for those of you that are less familiar with with the field, you can think of it in three different in which it acts. These are the classic actions of the GLP-1s. One, in terms of the brain, leading to satiety and a decrease in appetite. Two, in the stomach, decreasing gastric motility. And really important in terms of diabetes is increasing insulin secretion and decreasing glucagon, the counter-regulatory hormone. So these are the classic mechanisms. But what has made these drugs really revolutionary in so many ways is what they do beyond just. And that's where we're going to spend the rest of the session on. So here are the current indications according to the for the GLP-1s. And when I'm talking about GLP-1s, I'm really talking about semaglutide and tirzepatide, the two newer agents that are the more potent ones. Certainly, they're indicated for diabetes, but also for preventing the progression of chronic kidney disease, for the treatment of obesity, for cardiovascular disease, and obstructive sleep apnea. How common are these drugs being used right now? This was a survey released just last week, a national survey in the US. 1 out of 8 Americans has tried or actually, no, I'm sorry, is currently using a GLP-1. That's really astronomical. And you look at it's higher in women than men. And you look according to age group, those that are 50 to 64 have the highest use. Um, uh, Almost a third have tried, and 22% are currently on these medications. So I talked about um, redefining obesity and the importance of the tape measure. We talked about the indications. Where are we headed? And then I'll give you some clinical tips, clinical pearls on using these medications. And then we'll end just last couple of minutes on what's in the pipeline. So where are we headed? So we know that obesity in and of itself affects multiple organs, and it increases the risks of type 2 diabetes, kidney failure, osteoarthritis, um, obesity-related cancers, about 20 of them now, stroke, heart attack, sleep apnea, depression, and Alzheimer's. And so as potent drugs have become available, there have been efforts to study them on each of these other indications, and that's what I want to share next. So there are already large a good size randomized control trial data to show that GLP-1s are effective at all of these, whether that is diabetes prevention, people with pre-diabetes, 80% were able to prevent them progressing to diabetes, uh, osteoarthritis reduction, impact on liver disease, polycystic ovarian syndrome, peripheral arterial disease, and heart failure. So stay tuned. I suspect many of these will be, they already have the pivotal trial completed, and I suspect in the coming months, we'll see these added to the indications of the two agents on the market. What about new indications beyond that? So this is not based on randomized controlled trials, but look retrospectively at people and saying, well, we looked at, 100,000 people. Some of them are on these agents and some have not been. And what's the likelihood of them developing these conditions or being better off with these conditions? And, that's an association. It doesn't prove it. You need a randomized control trial, but the list is impressive. You know, in terms of addiction disorder for tobacco and alcohol, Alzheimer's, there's a very large randomized control trial with semaglutide underway right now. It will read out next year that will look at whether it can slow the progression of Alzheimer's disease. Um, Parkinsonism as well is being looked at. Cancer prevention, good association data that it can be effective. Interestingly, psoriasis and lupus, diseases we wouldn't have thought were really weight related or, that these drugs would be effective. There are association studies for them, and there are really more and more that are coming out each month. So with all of that, where are we now? They're essentially two the most potent agents, and that's what I'm focusing on. For tirzepatide, it is approved currently for diabetes, obesity, and sleep apnea. But one will imagine in the not too distant future, indications for heart failure, liver disease, and kidney disease, and still doesn't have the indication for overall cardiovascular. In contrast to semaglutide, which is approved for diabetes, obesity, cardiovascular disease, and prevention of chronic kidney disease, tuned for based on data that already exists for indications on heart failure, liver disease, and peripheral arterial disease. So let me share just some clinical pearls, having been using these medications for quite some time. So speaking to many colleagues, I still see patients at the Johnson center, and I'm an endocrinologist by training. That just mentioned that. So, um, in terms of tolerability, the key is really starting at the lowest dose and going up slowly. And in some cases, that month to month titration of dose may need to be extended even further. And there was a recent study that looked at if you actually tailored your titration to the patient and their symptoms, most all patients were able to tolerate the medication if it was done slowly enough. And so being mindful of that is really key. Um, the other is some advice for patients when they're taking these medications. I often tell people, it works by slowing gastric emptying and the sense of satiety. That's part of how it works. What I often tell people is, using these medications, um, sit down to your meal after a bit and then stop and wait, 5 minutes or so to let your brain catch up to your stomach. Um, you may find that you're actually full at that point and don't need to eat the other half of the meal. If you're not, go ahead and eat the other half of the meal. But the problem can be that, particularly for people that eat fast, they sort of eat before the signals catch up, and then they end up feeling overly full and sick, and that can be a reason why they don't tolerate the medication. Um, it also appears that fatty foods are more likely to lead to the GI side effects. And again, the most common side effect with these medications are GI related. So try to avoid fatty foods, and carbonated beverages also can make things worse in terms of the GI issues. Uh, One of the things we know about these medicines, and it's not unique to these medicines, but to any strategy for weight loss, is that you lose fat, but you also lose some muscle. And that muscle loss can be mitigated to some degree by ensuring enough protein intake. Uh, that amount of protein becomes important for people on these medicines because they're eating a lot less. And so may have to be mindful to make sure they're getting enough protein. So the recommendations are zero point 0.8 to 1.5 grams of protein per kilogram body weight. For people that are older, it's more like the 1.5 is the goal. Um, and then the other thing that mitigates the muscle loss is strength training. That doesn't have to be joining a gym and lifting weights. It can be body weight exercises. There are many examples of videos online that people can get guidance on. So as protein and strength training can prevent the muscle loss. One of the most potent things about these medications is they address food noise, this thing that people talk about, where they're always thinking about food, and by treating that with these medications, they now can really think not only not have to just focus on the quantity of food because the medication sort of helps with that, but the quality of the food. And now your discussions and team member discussions with them can be talking about the quality of the food that they're eating, whereas before it was hard to get to that because it really was about just reducing portion size. So the new federal recommendations have had a monthly cost for every similar to what the direct consumer costs are. But the new proposed Medicare coverage is significantly less, and you can see that here. Um, Again, the problem with these medications have been their cost and people not able to access them. And the concern is, of course, that we'll only widen the disparities in health that we have, where some people will be able to afford these medicines and many not. Uh, there are compounding versions available and at a lower cost. Again, it's a buyer there because it's not always clear what is being provided. And finally, people have been, because of the cost, largely experimenting with microdoses, taking much lower doses, seeing if they can have an effect. My caution with that would be that those other effects beyond weight that we described of cardiovascular disease and sleep apnea, stress, etc., those have only been studied at the higher doses, and so you may not get that at the low dose. Um, Um, and then I'll just briefly mention that, been really exciting about patients is understanding that their outcomes are beyond weight loss. And we know that weight loss improves many things, but recent data from the trial with semaglutide was able to demonstrate even in individuals that did not lose much weight at all, there still was the cardiovascular benefit. And there's been a lot of thinking to try to understand how is it doing that. And this recent paper and diagram outlines some of the anti-inflammatory mechanisms that have been demonstrated with these medications. And so it seems as if only do they have an effect on weight, but these anti-inflammatory effects may explain things like the effect on lupus and psoriasis and cardiovascular disease and potentially Alzheimer's. Um, I'm going to maybe stop here before we get to the pipeline and maybe see, Ranjani, I didn't know if you had some other things you would do. And then with time, I can certainly go back and talk about some of what's in the pipeline.
Yeah, no, that's great. Feel free to continue. I'm just going to go ahead and, while just jump in here like a quick commercial break, but not too long. I just want to quickly say, all of you here, I just want to give you a quick introduction of CharmHealthSquare. You guys are all here because you've joined our CharmHealthSquare community, and this is a place built for prescribing clinicians, and it's free for anyone who is actively e-prescribing with e-prescribing credentials on CharmHealth. You can use it through a single sign-on, and that's how you got in here. So thank you so much for joining. Clinicians outside Charm Health can also join if they're invited, and with ID verified. So we keep this network tight, clinical, and distraction-free. So just wanted to say that. And essentially, we created this community because we heard from a lot of independent physicians that they wanted a community feel. So we created this space just for you guys. Um, so I wanted to also say we have about 600 plus people who have joined the community, about 650 or so. However, 122 people of you have actually introduced yourself. The value of introducing yourself is that you get into our live clinician directory, and other clinicians can find you. And also, you can, people can, when they look you up, they know who you are, and we build. This is how we'll build our community and actually build our collaboration. So I wanted to give a very quick way on how to do that hello, how you'd introduce yourself. Um, and just so you can all, who, if you have not done that yet, you're able to do that. So if you go into your Slack channel and you go into the clinician director intros, which many of you have already done, so thank you so much. I'll go ahead and share my screen. You can see right here, many clinicians have introduced themselves, including Dr. Gabbay. And right on the right below here, there's a say hello button. And once you click this button, you will be able to, share your specialty, what your interests are, and what you hope to get out of this community. Once you do that, you can also, if you go over here, you'll be added to the clinician directory. So if you all go here and you see clinician directory here, you'll notice all the other clinicians that have added themselves. You can search based on other specialties if you need to talk to anybody, if you need to get maybe some sort of advice on something. And we have other clinicians who may be willing to share their thoughts about it. I'd also wanted to say that so once you join, once you've done the say hello and you join a clinician directory, then you can also then browse the other channels that are there. You can go to the channels. There's family practice, psychiatry, endocrinology. Feel free to add yourself wherever if you want to interact with these groups of specialties. It's super easy to find people. We're really happy to see the beginnings of community collaboration here. For example, Dr. Pam Gordon wants to start a channel on marketing tips. And so he or she is going to start a community like that. And we really want you all to make this community for what you need it to be. And we encourage this kind of dialogue, share your ideas, start a discussion, and help shape the space. We're looking for all of you to become our community champions. Once again, specialists can message primary care docs, psychiatrists can connect to family practice. Um, you can share your cases, ask questions, request second opinions, or just compare notes on how you run your practice. The bottom line here is this is a place to connect with your colleagues, ask for help, share what you know, and build a clinical community that actually feels very useful to you. And if you need any help, please don't hesitate to reach out to community@charmhealth.com. And also, you can leave feedback at one-feedback on maybe things that you'd like to see coming out of this community. I'd like to remind everybody, as mentioned earlier, that in one of our canvases, we've mentioned when you joined in, this is not a support channel. We're not here to answer Charm Health EHR questions. This is a place very dedicated to creating a community for you guys. Finally, I wanted to say Dr. Gabbay is available for questions via the Ask the Expert channel, GLP Dr. Gabbay. He's available from now until the 25th. He is a guest on our channel, so please do make use of him while he is here. With that, I think I have mentioned everything that I need to. I'd like to just take a quick photograph of everybody here. If we can all just share our videos very quickly. I'll take a quick snapshot and then we'll go back to Dr. Gabbay.
Ranjini, you're still sharing your screen.
Oh, thank you. All right. Thank you so much. I think most of you have shared your screen. If I'll just give a few more seconds. Sorry, not shared your screen, shared your video. So just give a few more seconds. Thank you. That'd be kind of neat if everyone shared their screen. Okay.
Are you able to go back to the slide with the three measures, the new measures with the ratios quickly?
Doctor, I think Dr. Gabbay can do that. I would like to just remind you all that a recording with the slides will be available. So just to, if you need it, and I also took a screenshot of a couple of the slides. So feel free to take a screenshot as in how you need. So I'm going to go ahead and take a screenshot, Mega, if you'd like to do that as well. Does everybody have their videos on? Okay. Give you guys 5 more seconds. Yes, ready? 1, 2, and everybody give me 1 second. Give me a big smile. Is Dr. Gabbay here? There he is. He's right there. 1, 2, and give me a smile. Maybe. Yes, wonderful. Thank you so much. Okay, appreciate that. We're gonna now we'll go to question answers and maybe does that answer your question with respect to like getting that slide? Can we just give you a recording if that's the only thing you need? Just for the interest of time?
Yeah, that's fine.
Okay, wonderful. Okay, with that, I'm going to hand it back to Dr. Gabbay. I think you're muted, Dr. Gabbay.
Sorry about that. Thank you. Let me know what you'd prefer. Should we go to question or do the pipeline for the next few minutes?
So how long will the pipeline take? Because I think that's probably, do you guys all have and would you all like to see what's in the pipeline coming up before we go into Q&A? I think we're seeing some nods. So let's go straight into the pipeline and then we'll go into Q&A.
Okay. Here's that other slide that you asked about. Oops. But let me move to the pipeline. Sorry. Okay, so So the pipeline, there are 400 to 500 active trials, and we're talking phase 2 to phase 4 intervention studies that are registered on clinicaltrials.gov. So there's an incredible pipeline. And here's a question, and I don't know, Ranjani, whether we have this as a polling question or not. Um, if not, maybe people can just put in the number in the chat. So,
Sure. I can
um,
try to add it in, or we can do that.
okay. So here's the question. There's a lot of activity of drug development, and they're targeting different things. What do you think is the most important to develop? Something that's easier to take, whether oral or monthly, and there's efforts on both. Um, One that has a larger weight impact, and that's been largely using different combinations of hormone therapies. Tirzepatide is GLP-1 plus GIP. There are other hormones that are being added to try to get larger weight loss. Is it more important to have muscle sparing? And that's where there are a number of agents that are pro muscle growth that are being added to GLP-1s, or agents that work through the amylin system don't seem to have the muscle loss effects. Um, or medications with less side effects, particularly around the nausea issue. Again, the amylin analogs, they've not been studied head to head, but it looks they may have less side effects. Or agents that are better at one of the particular subpopulations, whether that might be a particular comorbidity or whatever. Then finally, is it something that I haven't mentioned here? So which do you think, if you were given $100 million to develop a new drug in this class, where do you put your money? And if people want to just throw a number in the chat, 1 through 6, it'll be interesting to see what you all choose.
I just went ahead and
Oh,
launched
and
that poll.
perfect. Even better. Okay, do it. Let's do it the high-tech way. Perfect. Thank you. So yeah, which of these do you think is the most important to do?
All right, so I'm just going to go ahead and end this poll if everyone has responded, and I'll share the results.
Great. I'm curious to see what people choose. Uh, ooh, muscle sparing. Interesting. Yeah, pretty overwhelmingly. I'll tell you that I've used this poll with different audiences, and I had a recent opportunity to share this with a group of people that are in the drug development. They also thought this was one of the most important. The other fascinating thing is that if you patients, what they would most like to see, muscle sparing not on the list. We talk a lot about muscle loss. Um, Most patients do not, overwhelming number of patients do not complain about muscle weakness. If anything, many of them feel better on these medications, and so it's sort of interesting. Um, so I'll just share a couple that are in the pipeline, and there's a lot. Um, so this groups them by different areas, whether they are better GLP-1 agonists at the top, whether they're agents that work through amylin or amylin plus GLP-1, um, agents that work through GIP or GIP combinations, and you can see that on the upper left. Uh, then there are triple agents, GLP-1, GIP, and glucagon agonists. And And you see other combinations here as well as NPY. And so it's really a very robust set of agents. The ones that are closest to FDA review, one oral semaglutide, a higher dose than what's currently available, is already under FDA review. And so we look forward to seeing that data. Another oral agent that works differently and is not the same semaglutide. There's published, presumably submitted to the FDA anytime now. There's a dual GLP-1 GIP that has phase 2 data already published. There's the triple agonist, retatrutide, which has the most potent effect on weight. That has a phase 3 trial going on right now. And then finally, a amylin analog plus semaglutide called Cargosense has already had phase 3 data published, and therefore we expect to see with positive results, and therefore we expect to see that to be sent to the FDA any time now. So, it's easy to imagine that most, if not all of these, will be on the market within a year, which is pretty dramatic. So, what I talked about today is rethinking obesity and particularly the importance of using a tape measure to get a sense of fat presence, the current indications for GLP-1 and the large number of future indications, and then a taste of what's in the pipeline where clearly we're going to see a lot more medications available. And our challenge will be to how to decide between all of them there could be, as many as 8 to 10 drugs in the next year and a half. So that said, I hope covered some useful information for you, and I'm glad to answer any questions.
All right, we'll now open the floor for questions. You may see, do we have the ability to raise our hand here? Let's see. If you can just go ahead and unmute yourselves. I don't see that ability at this second. And you may ask your question.
Do you have any dose changes or concerns with doing the GLPs with any, like your psychiatric patients, the ones that are in SSNIs or SSRIs? We're seeing such weight gain on antipsychotic meds.
Yeah, that's a great question. And that has been an unfortunate side effect, as you know, of the antipsychotics in particular. There doesn't seem to be a need for any dose changing. There have been some studies in those populations. There's no reason to think that it would work less effectively. And again, it's about titrating so that they tolerate the medication, and whether they may be, like stay on the medicine if they have side effects is something to keep in mind. So I, I like the idea of starting at certainly everyone on a low dose, but you may need to titrate the medication slowly. The other thing I would just say is, because we started at a very low dose and we gradually go up, I think it's important to set expectations with patients about when they expect to see the weight loss, because since you're starting at such a low dose and you're increasing it monthly, to get to a really effective dose is likely to take several months, and therefore they're not going to lose any in a month or two realistically. So, I know a number of folks that stop them for months saying, well, I didn't lose any weight. This doesn't work. It takes time, and that's an important message to give out.
Have you seen any issues with the compounded medications, like semaglutide's compounded with vitamins, vitamin B, and tirzepatide compounded with NAC?
Yeah, personally, I've not seen anything. I think the challenge with all of those are, they don't run through clinical trials where we get a chance to really look objectively at the data. So it's a little bit hard to know.
Right.
Uh, yeah, I think that's the challenge,
Yeah, but
which is
some of my patients are going that route because they're not getting approved through pharmacy to get so um, that
yeah,
was kind of
and
my concern, just following, uh, adding more when they're
yeah,
already struggling. Yeah.
yeah, no, that's a really good point. And in that survey that I described, like people are on a GLP-1, they look percent are getting it from their clinician, their physician, versus somewhere else, presumed compounding. And 80% were actually prescribed. The other 20%, again, through sources as you describe. Again, that's where the access issue is, and the cost is really a challenge. Hopefully, if the announced plans with Medicare happen, that will lower, at least for that population, and there'll be other sort of commercial and other payers may follow suit. Um, finally,
I'd like,
Thank you.
I'd like to go ahead and actually, I've seen numerous questions in the
oh,
chat.
great. Okay,
Um,
good.
so what kind of inflammatory diseases or conditions can this medication address? This is by Dr. Kevin Farrell.
Yeah, sure. It's a good question, and I think honestly it's early days. We have seen data in both lupus and psoriasis published, uh, and so we'll wait for larger trials to be able to see if that sort of pans out. But those are the two that have been most studied to date.
Hmm. And then I have a question from Kyla, Dr. Kyla Thamert. Curious what your thoughts are on the long-term use of GLPs for either maintenance of weight loss or other benefits, such as anti-inflammatory effects or improvements in mood.
Yeah, well, first of all, I think it's important to highlight that these are really long-term medications, just in the same way as we think of treating blood pressure or lipids. They're really long-term medications, and when one stops the medicine, they stop working. And honestly, that shouldn't be a surprise. Uh, I think the safety record is quite good. This class of drugs has actually been on the market for 20 years, which is, quite a long time. So we do a fair amount about it. I think the impact on depression and psychiatric illness, we see a number of association studies that show that there. We're waiting for some more randomized controlled trials to confirm that.
Just to follow up on that from our question bank on Slack, is there any evidence that GLPs result in depression or suicide ideation?
Yeah, that's an important question because early on that got flagged as a concern in part based on earlier medications. There was a medication called Ramonabant that never made it to market, but basically got removed because of increased suicidal. So this has been studied pretty carefully with these drugs, and there's clearly no increase in suicides associated with the drug. Whether there may be a decrease, though, but there's certainly no increase.
Anhedonia in patients who feel blunted after starting GLP-1s. Any recommendations?
Well, I've not seen that. If anything, well, I'll scratch that and say what people do describe is not often enjoying food as much, alcohol as much, and depending on how much of a thing that is, that can be problematic. And it can also have it socially where, we're coming to Thanksgiving and, it's all about eating a lot. And these individuals are not going to be able to eat a lot. And if they do, they're going to feel terrible. And so the hope is as more people are aware of these medications, there'll be understanding around the dinner table that if you don't finish your plate, that's okay.
Then I have a question on any indications of alcohol use disorder, for mild alcohol use disorder, um, that you've seen patients have been helped by this. And I think it says I've had patients on it who says it has helped. And this is
I've
from
seen
Dr.
this.
Shakita. Yes.
Yeah, I've seen the same thing. A number of individuals that are consuming less alcohol. Uh, Whether it helps with those individuals, with a more severe illness, there's some early data to suggest that it does. But I think as a rule, most will end up drinking less, and that's not necessarily a bad thing.
And going on to the question bank that we have, what do we need to know regarding the prescribing for compounded GLP with the current state of the shortage resolution?
Yeah. Well, the good news is that the supply chain shortage is no longer an issue. They've been able to ramp up manufacturing, so that's not an issue. And based on that, the FDA originally allowed compounding because of the shortage. The FDA has now said no, there isn't a shortage, and therefore they're not accepting the use of compounding. There is a lot of legal back and forth between compounding folks, companies, the online companies, and the two major pharmaceutical companies. And so we'll see that play out. I think what's being used as uh, uh, a reason for compounding is that one can individualize the dose, and that's uh, depending on how you view this, the loophole that they're saying is that uh, we individualize a dose, so there's a need beyond the doses that are available with the current pharmaceutically produced medications.
Does anyone have any leads on what this is from Dr. Kevin Farrell? Does anyone have any leads on compendium of set of prescribing guidelines on a compendium?
You mean in terms of a series of guidelines that will be published? I know of two efforts, one by the American Diabetes Association that's in the process of creating an obesity standards of care. And the other is the Obesity Society, with several other organizations recently announced that they'll be doing a similar effort. Uh, so there should be something coming out soon. Having been involved in those kinds of processes, they take a long time. And so, it may be 6 months to a year before you start seeing these guys.
And I have a couple questions around insurance, Dr. Gabbay. So there was one in the channel as well as one here as well. And so I've had insurance approve GLP-1s after a PA, but they deny visits coded for obesity management, has no current comorbidities, but has a strong family history and wants to prevent progression while coding accurately. I want to prevent progression while coding accurately. It's difficult because I'm uncomfortable prescribing without follow-up, yet the patient doesn't want to attend visits that won't be covered. Prevention should save insurers money, so the lack of coverage is confusing. Can you explain the disconnect and offer any guidance as well? And there's another question, how can we get insurance companies to help patients and cover the drugs?
They're great questions. I don't know if I have the answer to them. I think we all struggle in work payers and documenting so that there can be coverage. And I would say that many of them are shifting their coverages. And if anything, the trend is less and not more because of the costs. The question like how how can this be when they have the potential of saving money? I think the challenge is the time course. So the average and I looked this up recently. Um, the average person stays with a health plan 2.5 years and then switches. And so for health plan A to cover a medication, they sort of have to see a reduction in cost 2.5 years. And that's for most people, these medications are not going to have that benefit right up front. It takes longer. Employers, on the average person, is with their employer much longer. And if you look at people over the age of 50, um, they're typically years with the average. Or now you can start that benefit. Um, Certainly, if you can find any comorbidity associated with obesity, be sure to code for that because that may be the entry point beyond obesity alone for the visit to be covered. And one that often are not diagnosing is liver disease and calculating a FIB4 index that you can get just from the lab or chart may be enough to indicate that they have some degree of liver disease, and that should be an indication for coverage.
Hmm. Um, Great. I have found more anecdotal studies with the mental health population. Do you know if there's any studies current in the later phases with this population with regard to starting GLP sooner rather than later after exhausting oral medications?
I am aware of studies that are looking at adding GLP-1 to these individuals. I'm not sure I've seen anything where it's earlier versus later, although that may be a secondary endpoint that they could then stratify the results based on, let's look at the people that were early versus late. But your point's well, that ideally you do this early on before there's a massive amount of weight gain, and they would run into all sorts of problems.
Is it possible that there are some patients that GLPs there are some patients that GLPs just don't work? Um, this doctor has a small percentage of patients that, despite strength training and going from very low doses to now almost a max dose, they don't seem to have any effect. And a follow-up question to that is, any, what do we know about the newest GLP medications pending FDA approval?
Yeah, those are good questions. And I would say, yeah, all people do not respond, and the response is pretty variable. And so, what you see reported, always, and the headlines are really around the mean weight loss. But if you look at that data, there are people that don't respond much at all, and I've had some people that don't respond. I'd say the vast majority respond to some degree, but it really is quite variable. And at the same side, there are super responders that have even more dramatic loss. So I think that is true of this medication, and thinking about other modalities for individuals that are not responding. Um, there has been some success switching from one agent to another, and that's always worthwhile. And then the other question is, in terms of other agents, I think in terms of loss, retatrutide, which is the triple agonist, had the highest reporting weight loss, and so you might imagine that medication being for these individuals that have not responded to either one or two hormone
Dr.
combinations.
Gabbay, could you just repeat the last sentence on what was the loss as well as which drug? So, because it got cut out in and out.
Yeah, sorry. So retatrutide, which is the triple agonist with the GLP-1, GIP, and glucagon, that had the largest amount of weight loss of any of the trials, and that may be the kind of drug that we go to for these individuals that haven't responded to one agent or two agents.
What do you recommend for GI transit slowing and secondary constipation that often occur?
Yeah, the one for individuals with nausea, Zofran can be something that helps bridge that initial experience. For most of these side effects, they get better over time, and so sometimes it's just bridging that period of time until it gets better. For the constipation, you know, fiber and fluids, and can't emphasize enough the fluids because these individuals do need to be reminded to take in enough fluids because again they're not hungry, they're not thirsty, and they're consuming a whole lot less. So, fiber supplements plus sufficient fluid, I think, is it can be helpful.
Um, so when people stop medication, there is a question, does it stop working? And then if they do gain the weight all back, the question is, are they able to maintain their current weight or do they gain the weight all back?
Yeah. From everything we know, they regain the weight, and it's one of those funny things that we, you know, I do a lot of press stuff, and it's one of the most it's one of the most common questions that come up, um, and I sort of say, well, why don't we sort of question that about blood pressure medication? If you stop taking your blood pressure medicine, will your blood pressure? Oh, of course it will. Yeah, that's like that shows the medicine's working. Um, so I think that's a challenge. The other thing I'll mention about is that is quite interesting is there is a concern that when people regain, they actually regain more fat than they and so if they were to go through several cycles of taking off the medicine, regaining, they start shifting their makeup to have even a higher percentage of fat than they have muscle. And so that's a reason of caution for those that sort of cycle. And that's true not just for the GLP-1s, but anybody that sort of has this yo-yoing diet experience.
As a psychiatrist, let's see, one second. Looking for questions here.
I'm
So
glad
there were
that
some
there are a
questions. A
lot
lot of
of
psychiatrists.
questions. Yes.
Yes, a lot of psychiatrists here, so they wanted to know if they're able to prescribe, and I believe the answer is yes. And people have responded to those questions. Um, do you feel that the pipeline research will eventually pull back the medullary thyroid cancer contraindications? Medullary.
Yeah, maybe just background for people on that. So one of the sort of warnings is around the incidence of medullary thyroid cancer. That really is something that's been around for a lot of years, and it really was based on animal studies with the early GLP-1s. That's not been seen to be an issue over the years with these medications, but it has not been removed. Turns out removing warnings from drug labels takes a long time. And the example of some of the black box warnings on estrogens as an example, whether you think that's right or wrong, it demonstrates how long it takes to make that change. I certainly don't view that as a concern with these medications.
With the immense studies coming through the pipeline, do you feel that biomarkers, genetics, gut integrity will be highlighted with influencing prescribing in the future? If so, what
Yeah,
biomarkers are you aware?
yeah, that's really an interesting idea. I think that eventually, as we understand the medication better, have more options, I think we'll start and some head-to-head trials, frankly, we'll be able to start to sort of tease out patients do best on which medicines. And that's where those could be helpful in predicting that. And that could include the microbiome. I think we're sort of early in that sort of discovery phase.
Any trouble? A doctor here is asking, any tips for helping patients that just don't want to eat? Some of our patients are having trouble getting enough calories.
that is a concern, and if they're really losing too much weight and too rapidly, I typically will want to lower the dose to not have it have such a powerful anti-appetite effect.
Yeah. With what would you recommend? What would be recommended? What would a recommended maintenance dose be to avoid rebound weight gain?
I think the rebound weight gain is as far as we know inevitable when one stops the medication. Uh, and so it's not really a dose dependent sort of effect. So at whatever dose you were and whatever amount you lost, you're likely to regain that on stopping the medication. On another side of the question would be, uh, what is the dose that I want to try to get somebody on? Uh, and generally, it's the highest tolerable dose that they be on uh, with not too much weight loss. Because again, as the question earlier was, if people are really not eating and their BMI is, dropping to unhealthy levels, you need to back off.
All right, I'm going to open the floor to anybody who wants to unmute themselves and ask any questions directly to Dr. Gabbay. We're just going to wrap up here in the next 5 minutes or 7 minutes. So if you'd like, please feel free to unmute and if you'd like, share your video and ask your question.
I just wanted to ask about binge eating medication and if that works well with the GLPs.
I can say I've had a couple of patients that was an issue for them. I think of one in particular who literally would like wake up in the middle of the night and just binge eat, um, and it really helped them. I think there's a suggestion that yes, it is helpful. Binge eating, of course, has as you can appreciate it, it's complex, right? There are psychological factors that are, this as well that make it challenging. But in general, I think it's certainly worth trying this therapy to help with it.
Thank you.
Is there anybody else? Okay, so wonderful. Just This has been an amazing gathering today. It was just fantastic to have Dr. Gabbay here, chat with us for this period of time of 70 minutes or so. Um, Thank you so much, Dr. Gabbay, for this very enlightening discussion. Um, I wanted to invite all of you to, if you have any other future questions, to please, as I said, he is available um, on the Slack channel. We do want to Dr. Gabbay, did you have any? We wanted to reward some of our. We had so many amazing questions today, and this extra little thing about even if you don't have any names, you and I can chat a little bit later, and you can give me yours, and I can announce them on the Slack channel. That's no pressure at all. But it's just a means for getting everybody to come to the Slack channel and getting them excited about our community and contributing to it. That's the whole purpose. So yes, two $50 gift cards are going to be awarded on the Slack channel in the Ask the Expert.
Can I ask
And
a quick question?
yes, please.
I've been using cagrilintide, and is there one of the articles I said don't go too high when using it with tirzepatide, but I'm not really sure dosing wise what's the maximum or what range we should be in for that.
I'm sorry, what was the medication you were using with it?
Cagrilintide, it's a amylin product,
Available on the market?
compounded.
Compounded. Okay, sorry. Yeah, I was like, wow, where did you get a hold of that? Uh, so there is a fixed ratio that had been studied uh, uh, headed toward that is Cargosense, and I don't remember the exact dosage of those two, but that would be the one that we know has been studied in large trials.
Okay, so just try to stick with that ratio.
And that's what we know, right? Anything else
Okay.
is who knows.
Okay, thank you.
Yeah. It's interesting to know that that's available out there.
It works amazing for people that
Yeah,
just I can't get them to move, 1 pound, 2 pounds a month, and I put them on that and 4 to 5 pounds, the next month. So it's been really great.
interesting.
Can I ask one more question?
Yes, please go ahead.
Can you just comment on the role of the GLP-1s and the Parkinson's studies or the retrospective data that we have thus far?
Yeah, what I've seen retrospective data, which is all that's available today, looking at a large data set of individuals retrospectively and looking at progression of Parkinsonism in those on the medication versus not, and there was less progression in those on it. Um, and the challenge there is there may be other reasons why those individuals were prescribed a GLP-1. They might have been healthier, or, I don't know what, confounding sort of thing. So we need to see a randomized trial, but it's certainly promising.
Sorry, and these were all patients who were on Parkinson's medications to begin with, or they were
Yes.
naive? Oh, interesting.
There
Interesting.
were already people diagnosed being treated. I don't know the particular what percent
Yes,
were on what
yes.
medicines, but yeah, they weren't newly diagnosed individuals.
Interesting. And were they theorizing at all about mechanism of action, or we don't know?
Yeah, we don't know. I think when there's lots of theories. So inflammation seems to be the in vogue theory these days
Yes, yes.
for yeah. Until we
Great.
know it,
Thank you.
it's easy to have a theory. Yeah.
Thank you kindly.
All right. All right. So before we end, I'd just like to ask, as the moderator here and as being the facilitator for the CharmHealthSquare, what would you all like to see in more of in this community, the CharmHealthSquare? I think your input is very important. It'll help guide what comes next. So if you can just put it in the channel, again, this is a place to connect, collaborate with other physicians. How can we help facilitate that? Also, if there's other topics you'd like to see, perhaps on HRT or Botox, or maybe you want financial guidance as well. Anything like that, if you could just put it into the chat box, it would help us. Feel free to share your thoughts. If you'd like to be up on more clinical news and guidelines and you want a single area to kind of get that would be useful. If that would be useful to you, please feel free to create any new channels or join any channels that are there. You may find those channels in the Slack if you go to the plus sign on the left-hand side, you'll see more options for you. How can we make this community absolutely useful and engaging and interactive for all of you? So please do put in your thoughts, and we can definitely come up and find experts just like Dr. Gabbay, share their expertise with all of you. So we'll just, take a few seconds. If you can do that, the more you share, the more we can tailor it. Thank you all so much for joining us today. A really big thank you to Dr. Gabbay for sharing his insights once again and taking the time so carefully to answer everybody's questions. I really appreciate that. And we hope that you found this session valuable, and we look forward to doing more and more of these sessions. You all have a wonderful rest of your day. I'll just stay on for a little bit more if anyone else is going to be responding back in the chat. And Dr. Gabbay, if you'd like to say any last few words, please go ahead.
I just appreciate you all hosting this and attending, and for being on the front lines of patient care and making a difference in the lives of people that need your help. So thank you.
Thank you so much. Appreciate that, Dr. Gabbay.
Mecca, by any chance, did you take a screenshot of that second slide with the new definition?
My name is Ranjini. I don't
Oh,
know
I'm
if,
sorry.
no worries. Mega's also on here. I don't know if she had taken any screenshots.
Okay.
However, this recording will be available in about, a week to 10 days max. It's usually just
Okay.
about a week. It will be available in the channel. I think Dr. Bay may have left our session. I can ask him
Yeah.
if he can share
Yeah,
the
that's
slide.
okay. I just was looking at that weight to height ratio number and I wasn't able to write it down.
Yeah, yeah, no, no, I know. That was very interesting.
Hmm.
So, definitely I will reach out to him as well. If not, you do have that video that's available.
Okay. Thanks.
Thank you so much. May I know your name, please?
Diana Giordano.
Okay, yeah, thank you so much.
Thank you.
Yeah.